We're at Trustville today. Thanks, Trustville, for hosting us. We got a full room. Should be a good class. We got Dr. Davidson speaking today on cardiac arrest. We got survival flight coming in just before the food gets here, and we'll do some airway management skills. We'll do some mega codes. I got a few fig trays for surgical airways. We should have both fellows and Dr. Brown coming out today as well. Just some updates from Brown. Remember, any airway that you manage as a medic, you got to document waveform capnography that you see it and a numerical value. Please put that in the narrative. That will keep you out of trouble. If you're a medic using a blind insertion device, an IGL or a King, when you get on scene, you should have waveform capnography, okay? If you're running a BLS unit or if you're an AMT and don't have access to waveform capnography, we're not going to ding you for not using it. But if you're a medic and you're doing a blind insertion device or an ET tube, you got to document waveform capnography. Standard of care, no questions, every time, no matter what. It gets you in trouble and people can die, okay? Upcoming, we're in Mountain Brook on this, the 28th. Is that when it is, Chief?
Yes, sir.
28th. We'll be in Gardendale the second Wednesday of October. Oxford the fourth Wednesday. We'll be at the state conference the first week of November as well down in Orange Beach. EMS Challenge will stream live from there on that Wednesday. Then we have a skills lab and surgical airways all afternoon. You registered like you would for the conference. And then we're working on December schedule. So, all right. We got about 200 folks online today. So if you have questions, raise your hand. We'll give you a mic or use the overhead. But still, don't be shy. Thanks for smiling. Davidson.
Davidson, you got your mic on?
Yeah, I just turned it on. Can you hear me? All right. Like Dr. Ferguson said, I'm Blake Davidson. I'm one of the EMS fellows. I'm originally from Arkansas, did my residency in Kentucky, and am now making my tour around the South, complete in Alabama. So forgive me if I bring any of the Midwest and Kentucky around here. Today I'm going to be talking about cardiac arrest. Okay, cardiac arrest for the most part, for most of us, is pretty straightforward, right? We got ACLS. We all know how to do all that stuff. So it's kind of giving some background on why we do some of the things, and then at the end of the day, we're going to talk about kind of when we go off that algorithm, or when we can kind of think about why the patient coded in the first place and how we ended up getting to the situation rather than just being straight algorithmic type practitioners, right? So, you know, it's cardiac arrest, but really in my next lecture, it's called pediatric resuscitation, right? So how can we actually evaluate the patient, look and see what's going on, and manage the patient. Okay. There we go. All right. So why does any of this stuff matter? So, you know, out of hospital cardiac arrest is extremely morbid, right? Not many people that experience this event survive. Happens about 340,000 adults per year. Survival rate is around 11%, and that is in cases that are run by EMS. That does not include the cases that there's no CPR or advanced care that is attempted. So 11% in EMS treated cases. Overall survival rate is about 5.4%. The survival rate increases if you're in a public place, right? It makes sense. If you're out in the trailer out in BFE, it's probably not going to be a very good chance that you're going to survive out of hospital cardiac arrest. If you're in the middle of the mall and 100 people see you and they immediately call 911 and somebody starts CPR, then you've got a little bit better of a chance of surviving. You know, that actually, it increases even more if you're talking about people that arrest in the hospital. You know, they actually have, you know, close to a 30 or 40% chance of survival. Incidence is higher in lower socioeconomic populations, which makes sense. They have lower access or less access to care, and a lot more barriers in order to be able to get care. And actually, they do not want to make the phone call in the first place, and many times. Circadian rhythm, just meaning that there's a higher incidence in the morning and in the evening. We all kind of know this, right in the morning when everybody wakes up and getting their day going. We get a lot more phone calls, and then toward the end of the day, once people are getting off work. The highest risk patients are 45 to 50-year-olds, and the majority in males. So, you know, Dr. Ferguson's on the good end of life. He doesn't have to worry about this lecture note too much. So what's that? So again, so keys to success. So what makes someone has a higher likelihood of survival, right? So we've got age here. If you got an age less than 75 years old, the ODs kind of a reference to what's called the odds ratio. The higher the odds ratio is going to be the higher odds that someone has a likelihood of survival, right? So 1.6 kind of gives you a little bit of a higher rate than the average of being of having a success rate for cardiac arrest. And success meaning getting back a pulse and having a fairly decent neurologic outcome. Does anybody else have any other like ideas of what may lead you to success for successful resuscitation? Like what factors come into play? Mm-hmm. Yep, absolutely. I think all Alabama football fans, regardless of the team, are in a struggle this week. Yeah, so age, kind of where they are, early access to bystanders. So that's the odds ratio. They hit the first one right on key. So it's odds ratio of 4.4. And if you code in front of somebody, you have and somebody actually does something to help you out, you've got a lot higher likelihood of survival. And why is that, right? So what's the cost? What is helping you out in that situation? Other than the obvious. Yeah. So what factors come into play if you're out in, you're out somewhere, like what's going to happen? What chain of events is going to happen to be able to make this the odds ratio 4.4?
You got more manpower.
Right. Right. So and it's the quickness of action, right? How fast stuff goes on. So not, initially it's CPR. People are going to do CPR, but there's actually a lot of barriers of bystanders not wanting to start CPR for many different reasons. As to either they're scared, they don't know how to do it, they're afraid they're going to hurt somebody. But the biggest thing is that they're probably going to make a phone call, and that's going to be the biggest thing. Is someone's going to see it and they're going to call 911. And that's going to get them access to care the fastest. So again, this changes even more. Early CPR by the bystander increases your likelihood even more, right? So these are kind of additive effects there, the 4.4 and the 3.7. Early defibrillation, less than 8 minutes. That's why we focus on the response time of 8 minutes is kind of why they've picked that in cardiac arrest. Gives you a odds ratio of 3.4 in cases that have a shockable rhythm. If you have an ALS crew, it's 1.1. Overall survival rate, again, is about 5 to 10%. So we know in the large majority of these cases that when we go out there or when we have a cardiac arrest case, 90 to 95% of those patients will not survive, will not make it out, or will not make it past that day. And that is disheartening, but for those 5 to 10% of patients, it really matters, and we need to be prepared and be able to do everything we can. So the kind of good and bad thing is that the CARES data that is out there shows that there is an 8-fold increase in the areas that see over of success and areas that see over 150 cardiac arrests a year. So this kind of leans towards places like Seattle, who is the top of the top of out of hospital cardiac arrest. They have a significant amount of great outcomes from cardiac arrest. It's because they see a lot and they do a lot of community outreach and bystander CPR. Areas that see a lot of cardiac arrest are obviously going to be better at cases or at places that don't see a lot of cardiac arrest, and that's not the fault of anybody that doesn't, but it is something that's interesting to be able to do. So that's why practice not only on days like this at Alabama, at the EMS Challenge, but on your off days, going through, making sure that everybody knows what they're doing whenever this time comes, and be prepared whenever it does happen, right? Because it's all repetition, and a lot of, and especially in the EKGs, it's repetition from recognition of the rhythms. When you get on, when we get to the scene, the biggest thing, obviously, in all these lectures and everything that you're ever going to hear is going to be scene safety, right? You get to a patient's house and there's someone lying down in the living room in cardiac. I think it was here last time, right? Somebody said they were running a cardiac arrest and got bit by a dog, or a dog attacked them on the butt, something of that sort. So like, be aware of those situations too, right? Like if you're hurt, you're not going to be able to help the patient. So make sure that you're safe first. The emphasis here is going to be early defibrillation and early chest compressions, right? Everything else can wait. Those are the two things that matter more than anything else. Access, get IV access if you can. If you can't, get an IO quick, right? This person is dead. They're not going to mind too much if you drill into their bone. So go ahead and consider that early. I'm a big proponent of IOs, even in the hospital. It's going to be able to get you can put all your code meds through an IO if need be, and they're extremely reliable and very fast instead of digging around with an IV for too terribly long. Definitive airways, if possible. So if you've got somebody on scene, if you've got medics on scene that can intubate, then do that. But that is not a priority in cardiac arrest. And for the most part, compressions are going to be your utmost importance. And if you're in a bind and the airway is difficult, or you don't have the manpower to be able to get an airway, and you've got a supraglottic device like an iGel or a King or whatever else, that's going to work 99% of the time. And if sometimes in the hospital, or I'm not sure how some of these community places do it, but they'll leave the supraglottics in and run the code with the supraglottic in, even in the hospital, without getting a definitive airway or without getting an ET tube. If the end tidal looks good and the waveform looks good, those are the important parts of that factor. And then the other thing is what we'll talk about a little bit later when we go through some of these cases is the recognition of fixable problems, right? So the instinct is going to be get to a scene and run the code and push epi and then go to bicarb, and then somebody's going to talk about calcium at some point, and then we're going to kind of go back around like, was that VFib, was that not? But when you're thinking about these cases, initially algorithm based, right? We're going to go straight on epi shocks, looking at that. After that first minute, after you get a little bit calmed down and everybody's kind of looking at the situation, and you all get to that point where you've got access, you've got the patient on the monitor, and you've given some drugs. Now we start to think about why. What happened before this patient arrested? Can I do something that's different to be able to help the patient out? Okay. So we talk about compressions more than anything. That is going to be the most important. Again, early compressions have a higher likelihood of survival. We're going to do it at a rate of 100. If you've got a Lucas device, those are extremely helpful. And most of them even have like some of the Zoll devices have like a manometer on them, to where that if you push it, it'll actually give you a beep at 100. And so instead of having to sing whatever song you're singing, whatever tune you want to hum, you can hit the manometer and keep you on there. But 100, the biggest thing is to actually be able to get a decent chest recoil. Sometimes people are just wanting to go after and go nonstop, and what they're not doing is not allowing that chest to rise completely. Well, if you don't allow the chest to rise completely, why is that a problem? Exactly. You're pushing all the blood out of the heart whenever you're pushing the chest down. Whenever you allow it to rise, that allows the heart to open back up and then naturally fill, right? And if you don't allow that to happen, you're not pushing any blood around, right? So it's important to be able to actually get that chest recoil. Lay rescuers, so obviously not us, but bystanders. Compression only CPR is probably is kind of the new thing where we're not doing any rescue breaths, and that's kind of the important thing for us to know is that airway is important, obviously, but it is not the priority. Okay, so get it whenever you can, but make sure to get compressions and defibrillation. I don't think any of us are probably using monophasic devices anymore. Do you guys know? Or do you know if anybody's using monophasic devices? So these are talking about, whether your life packs, your Zols, most of them are all biphasic now, meaning that it is a continuous circle of energy that's being pushed throughout the chest. It really just kind of creates whether or not how many joules you need to use. Should be at least 150. If I'm shocking somebody and they're dead, I'm gonna go to 200. It doesn't really matter. You're not gonna hurt them by going higher, and you're not going to risk anything by being higher. Okay, so 200 is fine. 150 is good, or if you want to increase, different. And we'll talk in the pediatric cases about pediatric voltages as well, or joules. From a compression standpoint, we've got multiple different things. So we've got the Zoll device over here on the, or not the Zoll, but the Lucas device over on the left, which a lot of us have seen and are familiar with. You've got your regular compressions, which are exhausting, right? Everybody's been a part of this. After about 2 minutes, I don't care how fit you are, you're gonna be a little tired after 2 minutes of chest compressions, right? And especially if you've only got 2 people and you're working around, that's one of the things to be thinking about from a transport situation and from a support situation is how many people do I have, and if you have other people on scene to be able to help you out, if you've got family on scene, utilize everybody that you can if need be. This other device, I've never seen it in person, but it's a pneumatic device that I think it's called the Thumper. Whenever I looked it up, but it is literally just a pneumatic device that goes down and basically punches them in the chest. Looks kind of barbaric, but it's a pre Lucas device. Anybody ever seen one of those? Yeah. I can imagine transport with that would be impossible.
Those things set back automated compression.
They set it back? They did what?
Everybody had such a bad attitude about automated compression.
And the ones that broke all the backs.
Just gonna keep the patient's position roll.
Yeah, I can imagine. Yeah, it looks like a jack. Like you would just back it down. There are a lot of studies on whether manual compressions versus something like the Lucas device are better or not. I think the biggest thing about Lucas device, and really, the biggest thing about compressions in general is placement. Make sure that you're in the right spot and you're actually compressing the heart and not the belly, or the right side of the chest, right? So those things are crucial. The biggest kind of downside to Lucas devices, they do have a little bit of a higher incidence of spinal fractures and some rib fractures. But at the end of the day, most of the spinal fractures that you see are not really life altering anyway in the patients that survive. So if you have one, you can use it, and they are extremely beneficial from a manpower standpoint. And if they come into the hospital and they've got a Lucas device on, I'm not taking it off. I'm leaving that on. So like we've said before, airway is important, but it should not delay or compromise chest compressions or the effectiveness, right? So if somebody's trying to intubate and they're having a hard time and it's making it difficult, I don't care, stay on the chest. Okay, don't stop compressions in order to be able to intubate somebody. The only thing that I do in the hospital, if I'm trying to intubate during a code, is I'll wait to try and intubate until we're about to do a pulse check, and that gives you that 4 to 10 seconds of period of time in order to be able to intubate with a free game. But otherwise, even at that point, it should not delay the restarting of compressions. It doesn't matter if you've just got a view and you're almost there. It doesn't matter. Start the compressions again and keep going. So if we're having a problem, being able to intubate again, supraglottic airways are the way to go, whether it be whatever device whatever you have available. Some important considerations for once you have the patient intubated is hyperventilation, right? We're going to be out on the arrest, and everybody's going to be worked up. You got the patient intubated, you got them lined, you got chest compressions going, everybody's adrenaline is pumping. First thing you want to do is pump that bag and squeeze it 40 times a minute, which is not what we want. Okay, you're going to be bagging at the appropriate rate. And what size bags do you use? Do y'all use the smaller bags, or y'all use the big bags, like the 1 liter bags? And those you also again have to kind of be careful that the tidal volume and that full bag, if you're squeezing all the way down, is going to be a liter, right? Most people's normal breaths, if I put them on the vent, I'm going to put them about 450 to 500, right? So kind of be aware of that fact that everything, if you squeezing that bag all the way through, you're putting them at a higher risk for getting a pneumothorax or some sort of barotrauma. And then you're also putting them at risk if you're hyperventilating them, squeezing that bag all the way through super fast, not allowing them to exhale appropriately, that you're just pushing air in, you're not allowing it to get out, and doing what's called breath stacking. Okay, and that can be an issue as well. The increased thoracic pressure is kind of what we're talking about from a barotrauma standpoint, overbagging, and then again, make sure we have end-tidal CO2. Okay, it's going to help us in many ways from a waveform standpoint, be able to confirm that you're actually in the right spot, and then from an overall resuscitation standpoint, it will be able to help us track if what we're doing works, right? If their initial end tidal was 10 and now it slowly starts to increase, it's up to 30, they might have some cardiac activity returning, right? Even if I'm in the middle of compressions, in the middle of actively doing something that I can't check the pulse, I can kind of start to think maybe something's happening here. Maybe at this next pulse check we'll actually have a pulse back and kind of be prepared for that. Does anybody know what can affect the end-tidal CO2 as a med that some people give commonly in code situations that can kind of be a red herring? Bicarb. So if you give bicarb, you can expect to see a rise in end-tidal CO2, probably going to be about 10 to 15. And the reason in that is that bicarb is broken down. It's a base, and immediately whenever it enters the bloodstream, it's going to be converted into an acid, and your acid is CO2. That's how you exhale it that way. So immediately your body's going to be like, oh, I didn't make this, I'm trying to get it out of here, and it's going to increase that end-tidal CO2. That lasts probably about 5 minutes. Okay, so if you give bicarb, you can expect end-tidal CO2 to be a little bit increased for the next probably 2 to 3 pulse checks. So just kind of be aware of that factor too, if you see it suddenly go up. So we all know this algorithm, right? So this is the kind of the thing we've been talking about. Start CPR. If they've got VFib or VT, then we're going to shock, and then we're going to immediately start compressions again. We're going to keep going down that rhythm. We're going to give our epi. If they're an asystole or PEA, we're going to give our epi and keep going down those routes. The things down here to remember are the reversible causes, kind of the things that, again, once we've gotten in our groove and we're able to settle down a little bit, what caused this? Like what is going on to be able to make this patient code, and can I help fix any issues? So I know you guys probably can't read that here, but we talk about the H's and T's being hypovolemia, hypoxia, hydrogen ion, meaning acidosis. So you think about that in some of your renal failure patients, hypo or hyperkalemia, hypothermia. The T's are tension, pneumothorax, cardiac tamponade, toxins, thrombosis, and pulmonary and coronary thrombosis as well, meaning MI. Right. Right. Who thinks they're good at determining pulses? You're not feeling for a pulse. You got a patient that's 250 kilos and have coded, and you're trying to feel a FEM pulse. Really bad at it. Really bad at it. Which sucks, right? Because a lot of the time we're determining the majority of our care on whether or not we feel a pulse or not. So I think the important part here is to try and realize is that obviously if you don't feel a pulse, we're going to continue. But the other thing is that we also overestimate feeling a pulse. So we have to kind of put in these other factors to play. Is their end tidal CO2 appropriate to actually have a pulse? Is their pulse ox appropriate, right? You shouldn't have somebody statting 70% with an end tidal of 10 that has a pulse that had been coding, and now you think you feel one, but none of those changed. Now, if they had a pulse of or if they had a pulse ox of 70 and they had an end tidal of 10, now their end tidal is 30 and their pulse ox rises to 95 and you feel a pulse, that's probably real, right? So, it's not everything is going to be black and white, but there are a bunch of studies out here that really kind of show how bad we are, and that's not only that's this. A lot of these studies include doctors, EMTs, nurses, techs, people that are doing this all the time. Doctors are probably actually the worst at it over anybody. What they do is they take these patients and they put them in the cath lab, and they've got arterial lines, and they know when they'll occlude the artery and have somebody put their fingers on them so they know exactly when the pulse is gone, and try and figure out whether or not the pulse is there or not. So about 45% of the time at the carotid, and it takes greater than 5 seconds to determine whether or not there's a pulse. Right? It's pretty bad, right? We want to be off the chest as little as possible. And if you're at the carotid, which is supposed to be the closest to the heart, 45% success rate. Not great. So we're talking again, kind of what are the other factors that can kind of lead us to the correct decision, whether or not what we're feeling is right. Anybody know what movie this is from? Major Pain. It's one of my favorite movies of all times. Damon Wayans. All right, so we talked here about rhythm evaluation. Like, do they have actual refusible rhythm? If this person is in VFib, you're not going to feel a pulse, right? So take a look at that as well. All right, talking about drugs. So what's our dose of epi in a code? Every 3 to 5 minutes. Amio? 100 and then 150, right? Lidocaine? Absolutely. Oh, gave it up. Bicarb? 50 milligrams, 1 amp. Whether or not you give it, whether or not it works, it's kind of one of those last-ditch effort things. I normally don't think about it until we're 15 minutes into a code, and I'm asking, is there anything else anybody wants to do? Somebody in the back is going to say, have we given bicarb? And I say no, and they say, can we? And I say, sure. And we do it, and it makes the numbers look better for a second, and then it doesn't anymore, right? The theory behind bicarb is that patients are acidotic. Some of these meds that we're given don't work. in an acidotic environment. So you give bicarb to try and help it out. Whether that works or not, no one really knows. Then calcium chloride. What's our dose of calcium? Yeah, I give 2. You can give 2 grams. All right, so we'll go through some cases at this point, okay? So case 1, we got a 23-year-old male who's playing soccer during an afternoon, a late day in August. He's in the middle of the game in a syncopal event. He was down for approximately 2 minutes and then regained consciousness. What do you guys want to know? You get called out for syncope. No medical history. It's warm outside. It's probably like 98 degrees outside. But he's cooled off. He's in a under a tent now. You do your physical exam. It looks normal. Patient's like, hey, I feel good. I want to get up and go. Can he go play? 23 years old. He can make his own decisions. No. No.
Or like heart racing or anything like that.
He was in the middle of playing and then just kind of all of a sudden fell out and didn't remember much.
12 lead.
12 lead. Okay. So I heard somebody say, did you eat before? So get like a blood glucose. Blood glucose would be normal. I think in this scenario, 12 lead is going to help me. If somebody's got syncope, get 12 lead. Get the EKG. Take a look at them. Okay. Again, vitals. This is going to be kind of a crucial thing as well. I had an internal medicine doctor that absolutely berated me for 8 months or 8 weeks during medical school. Every presentation, it's vitals are vital, right? So make sure to get a set. They're called vitals for a reason. This kid's normal. We get this EKG and it looks like this. It's got a bunch of circles on it. But what am I kind of looking for here? What is this going to show me? Do what? You talking about Wolf Parkinson White? This is it's a really specific EKG and one that's kind of funky, and interesting for young people that syncopize. Okay, you see how large these voltages are that normally aren't that big, and V2 it's normally a little bit smaller, but they're large in this one. And then does anybody know what that on the left circle over there in lead 2? Do y'all know what that is? It's a Q wave, right? So this specific in a young person that syncopizes during an athletic event can kind of lead you toward a diagnosis. What am I thinking of here? So HOCM, and you're right, LVH, right? So there's a bunch of different criteria to actually be able to diagnose someone with left ventricular hypertrophy. None of it matters. I don't really care about any of that stuff. I'm looking at kind of the clinical scenario. This used to be called HOCM, and it's not. It's just called hypertrophic cardiomyopathy now. This is something that needs urgent treatment, right? So if you're out and you get a kid that syncopizes like that, and you get that EKG that shows those big QRS waves or high voltage, you can kind of tell them that I think you might need to get checked out a little bit more and come to the hospital. He didn't say he syncopized likely for a cardiac reason in that case, and has a high likelihood of going into cardiac arrest. Okay. The prevalence is about 1 in 100 or 1 in 500 people. Mortality is 1 to 2%. It is the number 1 cause of sudden cardiac arrest in the pediatric cases. Getting into the dirty details, it's caused by mutations in the muscle layers, essentially, or in the muscle genes. It's autosomal dominant, so this is something that can be transferred into or transferred down the line genetically. So if you're talking with this kid, the family history is important as well. Any family history of sudden cardiac arrest under the age of 55 is a question I'm asking anybody that syncopizes, right? Kind of puts them a little bit higher risk for a cardiac cause of their syncope. Most people with left ventricular hypertrophy. This is it. So most of the time, why would you have an enlarged left side of your heart in most adults? Because if I get that EKG in a 70-year-old, I'm gonna probably not care as much. The heart's a muscle, right? It's working really hard, right? So yeah, so if you've got hypertension, you've got high blood pressure, your heart's having to work pretty hard to be able to push that blood out. Left side of the heart is the one that's doing all that work, right? And so it like any other muscle in your body, if it's having to work hard, it's going to grow. So if someone's got hypertrophy, LV or left ventricular hypertrophy in the absence of hypertension, and that kind of leads you a little bit more toward this diagnosis. It can only be made by a tissue diagnosis as well. So, most common arrhythmia in these patients is ventricular fibrillation. All right, case number 2. Got a 45-year-old female with past medical history of diabetes, end-stage renal disease. What's up?
Just a couple of points on that first one. Anybody that sympathizes with activity as a kid, you always got to think about the hokum. Another key thing you can do is you can listen to them. If they have a murmur, I mean, that's hokum until proven otherwise. So the answer would be no, you don't need to go back and play. Obviously, you're 23, you can make your own decision, but my concern is you may do this again and die. But syncope with activity is super concerning for that, whether it be a 23-year-old or a 14-year-old. Yep. I always get EKG with syncope, and then I always listen for the murmurs. And then the next question you're going to ask me is, what does a murmur sound like? Well, bring up your stethoscope and listen to the guys at the station with you and know what a normal heart sounds like. So that when you listen to someone with a murmur, you go, that's not normal. That's the murmur. So important finding. This is what you see on the TV, the 14-year-old playing basketball in high school that falls over and dies. That's my hope. And we don't want to miss it.
Okay. All right. So, yeah, 45-year-old female, end-stage renal disease on Monday, Wednesday, Friday, hemodialysis. She's got a history of hypertension as well. She had nausea and vomiting for about 3 days, had watery diarrhea. She hadn't been drinking anything. She stood up feeling dizzy, and she had a witness arrest. CPR was initiated by family members. When you guys get there, she's got no spontaneous breathing. Downtime's been about 10 minutes. What are we doing next? Yep, continuing CPR. Okay. And then what? What's some information that we can get?
She dialyzed recently.
She's missed dialysis because she felt sick. She just didn't go. Okay, put her on the cardiac monitor. Well, that's your rhythm strip here. Anybody want to take a guess at it? Okay, what makes you say that? Yeah, so you got those. Right, so it's kind of that wide stretched out QRS and the wide stretched out intervals all throughout, right? Sometimes it can kind of look like a weird ventricular tachycardia, but really it's that prolongation, okay? Hyperkalemia is said to happen in a very particular pattern, right? Starts off with the peak T waves and then starts to flatten back out and stretch out until you get that sine wave, right? And this patient is close. Depending on, there actually are correlations to how high the potassium is to what the EKG should look like. So, we're running ACLS, right? So we're going to be doing the regular ACLS meds, but what's a medication we can think of a little bit earlier in the course? Calcium, right? So that's kind of one of those things that I was talking about, is if we can kind of change our management a little bit through ACLS, right? We still do all those drugs too, but now we're thinking, okay, I'm actually going to treat the problem here rather than just reading off the page, okay? what does calcium chloride do in hyperkalemia? Yeah, stabilizes the cardiomyocytes, right? And that's the most important thing. It does nothing, has nothing to do at all with potassium. It doesn't treat that at all. It just helps the cardiac myocytes. So that'll help you out. So this is just another case of hyperkalemia, just going through kind of what some of these EKGs can do. This is getting a little bit further on down the road. And then I thought I had one too, but I don't think I do. Patients that are at risk, patients that have diabetes, patients that have chronic kidney disease, the hemodialysis patients that miss their dialysis, obviously, patients that are taking ACE inhibitors or potassium sparing diuretics, right? I actually had one of these the other day. A guy that was on, he just started a potassium sparing diuretic and had been taking it appropriately. He came in because he felt bad. His heart rate was 34 and his potassium was 8.3. So medical history and that is important as well. All right, case 3. We got a 65-year-old female. She's large, has a history of COPD. She's got cancer. She's on chemotherapy. She started having, she was getting up. She went to the restroom, had real bad shortness of breath. It's been going on for a couple of days, but got exceptionally worse. She had severe chest pain and all of a sudden lost consciousness. You guys get there, she's coding. She appears to be older than stated age, and she's cachectic. What do you guys want to know? What's that? Well, what? Oh, she looks like a skeleton. Skin and bones. She was. Yeah. I get yeah. Obesity and then cachectic. Yeah, it's my fault. I got to change the lecture. All right, you get the EKG, or you get the rhythm. This is a subtle finding. We'll go through here. Your second second strip that we're going to look at here. Pulmonary embolism can cause massive, cardiac arrest. Right? You got to think of these patients that are elderly. They've got a lot of comorbidities. This lady's got cancer. She's on chemotherapy. She's old. She's not extremely mobile. Cause sudden cardiac arrest, especially because she's been short of breath for a little bit, and then all of a sudden it gets hit. It's not going to change anything from an out of hospital management of your ACLS, right? Like, we're not pushing TPA out in the field, but getting that history, if you have time on scene, is going to be vital for us in order to be able to kind of put all the picture together and be able to treat them, right? There is some evidence of actually being able to push TPA in a code. There's a lot of controversy. Some people won't do it. I've seen it happen. I don't know if it's done or done a lot at UAB. The problem, if you push TPA during the middle of a code, you're running that code for 45 minutes because it takes a really long time in order for that TPA to be able to work, in order for it to be able to circulate it throughout the body. So if you push TPA, you are dedicated to that code, and you better be darn sure that's what you want to do. So it's a pretty big call in order to make, right?
The other problem given the thrombolytics and the PEs is by the time they get to us, you guys should have worked this code for a long time.
Yeah.
So now we got somebody that's had, active chest compressions for 30, 45 minutes, and now we're pushing a lytic. So they're going to be bleeding like a bear or a pig, whatever you want to say. They're going to bleed pretty bad. So it's better to get the lytics early on, but then we're kind of limited because we're not doing any kind of pre-hospital lytics in our state yet.
Right. So. These can be pretty gnarly, right? About a 45% mortality rate in people that have a pulmonary embolism that causes a cardiac arrest. That being said, it only comprises about 4 to 5% of all patients that have a pulmonary embolism. The large majority of patients that we find PEs in are fine. We're probably on the wrong side of pulmonary embolism detection as far as scanning too many people, but that's a different story. Yeah. Yeah. So this one, you want to, Jay? You want to talk about it?
So, I hate talking about this because it's not really that specific. You see it a lot with other conditions too. But in lead 1 and lead 3, you have this inverted S wave, and then in lead 1 you have an inverted S wave, and in lead 3 of the Q wave and the T wave are upside down, and so that's indicative of an S1 Q3 T3, which is showing this potential right heart strain from a PE. In an acute setting with no history of that ever before, with this decompensated situation, maybe, yeah, PE, okay. But in a patient with potentially long-standing COPD, that stuff might just be their chronic. It might not be as pronounced. So I would never go to the bank on this as my diagnosis for PE. But if you have like a previous EKG that's relatively recent, and then this, and you go, they're in some kind of hypoxic respiratory failure. All right.
Yeah. Again, it's the story, it's the history. Not one thing in general, or not one thing in specific is going to be able to tell you what this patient has, right? But if we got that history beforehand, I see this, I might push TPA in this patient. But, what's the most common finding? What's the most common EKG finding in pulmonary embolism? Sinus tachycardia, right? If you get asked what's the most common disease in any X disease, sinus tach, right? So you get all these things of what does this EKG mean? What does this EKG mean? But most of the time, the most common thing in almost any disease process you find is going to be sinus tach. But
how many patients do you see on a daily basis that are
Tachycardic.
tachycardic?
A lot, right? So it's pretty non-specific. So you got to, like he said, he put everything together to figure out what's going on.
Also, interesting, you're saying we scan people a lot for this. Don't get me wrong, we do. But I'm actually doing a study on it right now with some people over at our shop. And surprisingly, we find PE about 8 to 10% of the time we scan for it.
right,
Which is higher than I would have thought. I thought we scan way too many people and we never catch it. But actually, 8 to 10% of people that we kind of clinically think have it, 8 to 10% is a pretty good catch rate, I think.
yeah, it is. I think the counter argument to that is doesn't matter in a lot of these patients. There are a lot of older patients that have PEs that they have normal vital signs. They don't really have any other symptoms. We might be scanning them just because we got a question maybe, but we're finding a lot of these that are small, and then do we actually need to treat them, and what does it matter? So it is a lot of interesting literature that's out there now. We've got about 1,000 different tools to figure out whether or not we need to scan people now. All right, middle-aged male working on the 3rd floor of a hospital. He had a witness cardiac arrest. CPR was started by bystanders immediately. EMS on arrival. CPR is in progress, and he remains pulseless. This is a story of a patient that I had in the hospital in May. What are we doing next? Perfect. Okay.
I think the first thing we should do is ask why EMS is responding to inside a hospital.
We have EMS. We have EMS. We have paramedics in the ED.
American healthcare.
Yeah. So at UK we had our paramedics in the ED that responded to the call.
Well, I've worked them in the hospital, but not because I was working in the hospital, because we can't field work.
Yeah. No, so what happened? This guy, he was a 37-year-old guy. He was up on the 3rd floor of our hospital, which is the OB unit. His wife was 37 weeks pregnant with twins, and they were up there for a routine visit, and he just dropped while the OB was in the room. OBs don't generally deal with that too often, so they call downstairs and we send our people up. He got to the room. He got back to our room, and this is the first rhythm strip that I got. What are you doing? All right, light him up. All right, 200 joules to the chest. Let him go. Okay. Yeah, defib or synchronized or cardioversion. Defib. Not gonna have a pulse with VFib. I think my button's broke. What's that?
Okay, there's some arrows up on it.
Yeah, here's the button.
There's some arrows up there.
Gotcha. All right. Sweet. So he's got VFib. This is one of the better prognosis. There has a higher prognosis or a better likelihood of survival, right, with early defib. These ventricles are contracting at a rate of up to 500 per minute. It is a self-terminating rhythm, meaning that if they're in VFib for long enough, it will eventually stop, become an asystole. There are many reasons as to why people can go into VFib and cause them to arrest. So this one's pretty self-explanatory, right? It's just a guy that also went to VFib arrest. This one's going to be standard ACLS. Not really much to think about for this guy. The thing that this is important is in VFib and VTAC and these shockable rhythms, we have a few more options of what we can do in the hospital, especially for young guys. This guy, he coded. He was in my room in a matter of 5 minutes. He was intubated, shocked by minute 8, and he got central access and arterial line placed by minute 12. By minute 28, the cardiothoracic surgeon was in the room. We cannulated him for ECMO. At 35 minutes, he actually got a pulse back before they hooked him up to circuit. And day 12, he walked out of the hospital with a AICD in place. So these do have a little bit of or a much higher incidence of success. So if you work on a scene and the first rhythm that you get is VFib, or you have continued VFib, that is one that I would continue to work for a long period of time and talk about actually transporting them even during an arrest. And I don't know if Dr. Ferguson, if you have any other kind of recommendations from a VFib. Now, asystole and PEA are a little bit different. They have a lot worse prognosis, working on scene, but VFib and VTAC, I would be a little bit more aggressive of getting them into a hospital.
Hey, Dr. Davidson, I would say from local carriage data, I think what you said is not accurate. We're actually having better results in the non-shockable rhythm. You can see that in a lot of the carriage data that's emerging. So, in fact, the instance of VFib when EMS arrives is extraordinarily low.
Yep.
Yeah, the numbers are going down because we have better preventive care. People are getting AICDs and getting early cardiac caths and so forth. From a legal standpoint, the state says if somebody's in persistent VFib, VTAC, you have to transport them. I would argue, though, in any cardiac arrest that we work them where we find them. Before the days of Lucas, there was no reason to transport anybody with CPR. It was ineffective. Nobody survived it. I don't care what you tell me. I don't believe you. With the Lucas, I think that we have a better chance to do high quality chest compressions en route, but still, you need to work them where you find them. Like Chief was saying, PEA, asystole, we're seeing some of those folks come back. If you think about the cost of that, it's probably a secondary cardiac arrest, not a heart stop. Maybe there was a respiratory problem, an electrolyte problem that caused that, and we can fix that in the field. So still, early chest compressions, when you start chest compressions, you're on that chest until you either determine they're dead and you call it, okay, or they get a pulse back. So aggressive chest compressions, Lucas device on, passive O2. A lot of places are using blind insertion devices, iGels, Keens, even in the hospital. My thoughts for places that I'm working with, you can use an iGel as a stabilizing procedure as a medic. If that iGel gives you a patient with a great Sept, you have good waveform capnography, and they have a pulse, leave it in. If they don't have all three of those things, you need to start moving towards your video scope and get them intubated. Don't stop compressions to intubate, do passive O2, get them intubated, use your capnography. So working where you find them. State says, just a big fib, they got to go to a hospital. And at some point you may have to go, but working where you find them.
Yes, that was one of the questions we had come in was 20 to 30 minutes on the scene or secure equipment and patient transport.
Yeah.
Again,
So we got to get comfortable calling people in the field or stopping resuscitation in the field, not calling them, or stopping resuscitation. So if you're going to work a code, work it like you can get them back. Work them hard, do what you got to do. I'm like Dr. Davidson, I'm a big calcium guy. I think calcium works. It came out of the ASA guidelines in the early 2000s because there were no improved outcomes in the majority of patients, and I get that, but there's some patient populations that need calcium or they'll never come back. So working where you find them, work them hard, get an airway, do the things we can do, fix the things we can fix. If you get them back, great, move to the hospital. If you don't, there's not much more we can do at the hospital. Now, this is medical. Trauma is different, right? And I would argue that STEMI care is a little bit different. If you had somebody that had a big STEMI on the EKG, they go into V-fib, you're going to lay them back, you can start compression, you can give your epi, your amio, you can get them intubated, you're going to shock them. Those guys, if you don't get them back pretty quickly, and you have a Lucas, and you can be to a hospital in a few minutes, those guys are reasonable to pick up and go, because we can give them a lytic in the hospital to fix that clot. Does that make sense?
well, if the hospital's available and
If the
is
hospital-
willing to give the lytic and.
Well, that's true. So a lot of factors, but that's the only caveat to that. But otherwise, working where you find them. At some point, I would think that the state would move toward pre-hospital lytics like other states have done in the past. And that would change everything for us too. But we got to get the basic out-of-hospital cardiac arrest and 12 interpretation down to an art before we do that, so we don't kill people.
Yeah, I think it's useful too to note that a lot of the high performing agencies with high success rates are showing average loss times at about 30 minutes from ALS arrival.
Yeah.
So if you're picking up and leaving at 20 minutes, the data shows those patients don't survive.
Yeah.
I don't know why. I mean, that's just what the local data has shown.
And that goes again to, if you're a transporting agency, please put your data into CARES and make sure the data is real. We don't need fake data. We don't need BS. We need real stuff so we can look and see what we're doing. My hope is that in this region, we can kind of be all on the same page. So if you run a cardiac arrest and, you know, this part of Jefferson County is the same as you do in St. Clair County. And we can look at that information in a few years, kind of move toward the right direction.
We had one more question since we're paused, Doc. I'm sorry for the interruption.
No, you're good.
We had somebody ask on the PE case, what about false end-tidal CO2 and PE? And I commented to him, you know, any asphyxic arrest, we generally see false high end-tidal CO2 in the beginning, but that should normalize. I just don't know if there's anything specific about PE other than it's an asphyxic cause that would make persistently high false end-tidal CO2.
Yeah, again, like that would all fall into more of the history. I mean, if they just have like a abnormal, because you get sometimes you're gonna have like these COPDers that are chronically high, and you know they may have a high CO2 and have a respiratory arrest for the same reason. So I would think that it's all a clinical picture. It's not like you can't say this person's got a high CO2, they're probably gonna have a PD.
Right. I think the point is that, you know, a lot of the agencies, and I'm an advocate for not stopping just compressions just for the just to check a pulse, I think that you really ought to monitor resuscitation. When you have end-tidal CO2, you just wait till the end-tidal CO2 goes up.
Yeah.
But sometimes you do get falsely high end-tidal CO2. Sometimes it's retied and they don't have a pulse.
Yep.
And I think just anecdotally, we've seen that more with asphyxic arrest, or COPDers, like you said. Story might fit pulmonary embolism. We don't really know. But I still think you use end-tidal CO2.
Yeah, no, I agree.
Yeah, and you can have a high end-tidal CO2 with somebody, then you stop, you pause for a second to check a pulse, you don't have it, so Lucas goes back eating again. Those folks may just have poor cardiac output, and that's the problem. So the heart's perfusing the lungs, so you're getting CO2 gas exchange, but it's not strong enough to do anything else. So those are the guys that you think about breaking out your push dose epi, or making an epi drip and running that in there, or if you use a dopamine and run that in there, just if that makes a difference in improved cardiac output. So.
Very good. Thank you.
All right. So it's a case of a person going into VTAC here.
Go back to that one.
Uh-huh.
So why are they going into VTAC? Anybody know what's the reason, the cause of this one? Look at leads 2 and 3. What do you see? Happiness, sadness? Sadness. That's ghosts coming to kill you, right? So big STEMIs. Remember, things that make you go into VTAC, VFib, the STEMIs, and then cardiomyopathy or bad cardiac heart failure. So this dude's had a big STEMI going into VFib. So you should have been ready.
A bad day.
Yes.
Would not recommend. We talked about some of this stuff. So, know your local protocols as far as ECMO cannulation goes and VFib arrest. There are a lot of studies on VFib arrest and higher populated cities talking about the patients that or areas that have a lot more ECMO capabilities of just scooping and grabbing these people and get them to an ECMO center, and there really wasn't great outcomes. So that's what Dr. Ferguson was talking about, of working them on scene is important. So, all right. So say you're able to get Rosk and a patient loaded onto the truck. He's intubated. Lucas device is going. But then all of a sudden you start to notice they become more difficult to bag, a little bit harder to squeeze. O2 sats are going from 96 down to 80. Got blood pressure now 96, or it was 90 over 60. Now we got 70 over 40. What are we doing?
They're getting harder to bag.
Perfect. Okay. How are we going to do that?
You can look at your ETCO2, you can look at the line on the tube that you placed and make sure it hasn't moved.
Yep. Absolutely. If you've got another video blade, you can stick blade back in there, make sure it's still in the right spot, confirm it that way. That's good. Okay. You do all that. Everything looks great from that standpoint. Breath sounds. Okay. What are we thinking about? Pneumo, right? You've just been pouncing on this person's chest for 20 to 30 minutes, breaking all their ribs, right? And so what pathology are they developing here? Tension pneumothorax, right? So this person was fine. Now we've broken their ribs, created a hole in their pleura. We're putting in positive pressure ventilation, right, with our bag, and we're pushing a bunch of air into the thorax and causing this tension pneumothorax. So what are we going to do? Needle decompress. Absolutely, good job. All right, so this is Dr. Ferguson showed this in a lecture the other day. So you got an X-ray over here on the left-hand side, and that shows what a tension pneumothorax will look like. Most of the time, if you get an X-ray like this in the hospital, you're going to get made fun of because you should never have an X-ray like that. It should be treated. It should have a chest tube in it by the time that X-ray is taken. So this is in here just talking about kind of where we need to go, right? We've got the midclavicular second intercostal space, or right above the third rib. And why do we go above the rib? Got your neurovascular bundle underneath, right? We can also talk about going in the fourth and fifth mid-axillary line as well. Whatever you guys are comfortable with. State says you can do both now. whatever you guys have available. If you're in the back of the truck and this guy's happening, you're probably not going to be able to get them in a great position to do a mid-axillary line. So the mid-clavicular line may be the only one you actually have access to be able to do, and it's still just as safe. Those are all the. Do you guys have the decompression devices here? The stab and go. I think most of them are 10 to 14 gauge needles. If for some reason you can't find it, you're out of it. It wasn't stocked. Something got missed. Grab the largest bore, largest needle, the longest needle that you have, and put a catheter in the chest. So if it's a 16 gauge, 2.5 inch IV catheter, use it. Okay, just make a hole in the chest.
Is it category A or category B? A, yes,
A.
very good, yeah. If you're concerned about it, the patient's crumpling in front of you, get it done. Will you get fussed at the hospital? Potentially. That's okay. That's part of our jobs, right? If there's a big issue, email me. But it's category A. If you got a pneumothorax, now you think it's tension. They would die if you don't fix it. So fix it.
Promise the next lecture is shorter. Okay, guys. We'll do this this case. Take a 5-minute break and then go to the next one. Okay. Got a 65-year-old female, ovarian cancer, 3 days history of nausea, vomiting. She's been given antiemetics, Zofran, Phenergan, with her nausea. She's also been on levofloxacin for presumed pneumonia. Walking to the restroom and collapsed. What do you guys want to know? What do you want to look at? Same thing every time. I want to look at this cardiac monitor, right? Torsades, right? So what is torsades? Polymorphic VTAC, right? Polymorphic meaning that these waves, these squiggly lines, look different than these squiggly lines, right? So it's a funky looking rhythm. They all look all kind of jacked up. They're not the monomorphic VTAC that we see. It's not the small squiggly lines in VFib. They're kind of all over the place. It's a torsades de point means it's twisting on a point, right? So it's kind of twisted over. Heard somebody yell the treatment out. What is it? Bang. How much?
4.
You can give 2 to 4. Yeah. And over how long? Push it.
Slam.
Doesn't matter.
Yeah.
They're dead.
Yeah.
You're not going to cause
Pretty
any
fast.
further hypotension. Okay. So this is a self-limiting rhythm, right? It's they're not going to perfuse it, and eventually it's going to stop because they're going to die. You treat it the same way you treat VFib and VTAC, other than the addition of MAG. It's thought to be caused by prolongation of QT, right? So that's why the medical history, the medication history in this patient is important, right? We've got your levofloxacin, your fluoroquinolones can cause a prolonged QT. She's also taking Zofran, maybe taking Phenergan, which also increase that. You get an R on T phenomenon. Have you guys heard of that before? Right. So it's a process of where you get some cardiac signal in a depolarization point, and it causes this rhythm. Treatment's MAG. Going further, I'm gonna think about what else. Oh, this is talk. So this person's got a prolonged QT here, just in their normal rhythm. They hit, and then they go into a torsades like rhythm. Let's see if we can get through this one. This is the last one. All right. Anybody have any ideas? Reading through this real quick. You got a old boy. He's got bad heart, bad lungs, on oxygen, still smoking. Looks and feels like crap. Altered. These are your vitals. What's important about these vitals right here?
You decompensate. It's not just pressure low, O2 sats low.
Okay. What else about these vitals? What are you missing?
Blood sugar.
Heart rate and blood sugar.
And heart rate.
Right. So Get EKG, his heart rate. Anything odd about this heart rate? This
Multiple P waves.
It's heart block.
right. So what makes you say it's heart block?
P waves and Q waves.
Yeah. So you don't have a QRS after every P wave, right? And you've got this marching out, right? This guy's heart rate is probably going to be somewhere around 30 to 40. If I've got a heart rate that low, one of the biggest things I'm thinking of is heart block, right? Do these QRS march out? And same thing with the P waves. Okay, so what are you doing in this guy that is bradycardic, hypoxic, hypotensive? Right, put it on pads, start pacing. Okay, you can give atropine. It's not going to work if it's real heart block. Okay,
This one, Pat, what rhythm exactly was that?
this was complete
Second degree type?
third degree.
Third degree?
Yep, third degree complete dissociation.
Can you walk us through how you would interpret the blocks?
Yeah, so when I'm looking at EKGs, what I'm doing is I'm looking at it from a growth standpoint. I look at it from back here initially, right? The biggest thing that shows to me, or that is pointed out to me, is that it's slow. Okay, it's real slow. And then I start thinking, like, why is it? Is it wide or is it narrow? And this one is pretty narrow. A lot of the complete heart blocks are going to be a little bit wider because it's the ventricle that's causing the beat. But then I'm looking at there's a lot of stuff going on here. I'm starting to look at where are my P waves at here. Okay, I've got a P wave here that marches all the way up. This actually looks like a normal rhythm or a normal beat right here, right? If I were to look at this in isolation, I'm like, no, that's sinus. Okay. Then I've got another P wave that's actually kind of dug in over here. Got one here, and it's super long. That doesn't really doesn't really make sense. I've got another P wave that's dug. That's the P waves in complete heart block can kind of hide on you. So what I do in these, if I'm suspicious of heart block, of a P wave here, I see a P wave here, a P wave here. I don't see a QRS. I see a P wave here. There's one hidden around in here. And whatever, you can get a piece of paper. Okay, print off another sheet, get a piece of paper, mark on that piece of paper where the QRSs are. Okay, mark them there, move it over, and they should be in the exact same spot. If this is a complete heart block, these should march out appropriately. What you're also going to find is you're going to find the P waves march out appropriately too. So I'm going to grab, a P wave here and a P wave up in here, and then I'm going to march those out. And what you can do in those situations is you can find where the P waves hide. Sometimes they hide within that QRS complex, and it kind of will throw you off. But if you put your marker within the middle of that QRS system or within that QRS complex, it's going to line back up with the next P wave and show that these are beating out independently from each other. Does that make sense at all?
So question, how long does that take to go through to talk about how to figure out what's third degree? So in a patient scenario, sometimes these are tough to figure out. So even for me, I'm like, yeah, it kind of looks like third degree. So in my brain, I'm thinking, all right, I'm going to start having somebody get the monitor set up for pacing, let's get that situated. But at the same time, it's pretty easy to grab a box of atropine, push that, see if it works.
Yeah.
If it works, I'm done thinking,
Mhm.
right? If it doesn't work, then I move down my line. I think about calcium. I do calcium a lot of times for this because it increases contractility and blood pressure. If this were hyperkalemia, which causes slow rhythms, it would fix that. Probably not, because it's not a Y complex QRS that I can see from back here.
Mhm.
I'm thinking about push dose epi or start my dopamine titrating pretty quick. And I'm doing all that in a matter of minutes as we're getting set up, and I'm breaking out the gumption to start pacing this guy. If those medicines fix it, I'm done. If they don't, then I start pacing. What you don't want to do is sit there with that paper and look at it and start marching things out as your patient's there in front of you, heart rate of 30, looking like dirt.
Yeah.
Okay, so if you recognize it's third degree and you go straight to pacing, more power to you. If you're not 100%, you're concerned, start your therapy because, like you said, atropine is not going to hurt. Dopamine epi is not going to hurt. Calcium's not going to hurt. And sometimes those medicines will buy you some time till you figure it out into the pacing.
Yep.
How many folks have you paced in the past couple of years? I haven't paced many.
Uh,
What's you, Jane? Have you paced many?
Two.
two, yeah.
Yeah.
Most
so-
of the time, if you drip, we'll see if you might want to do that.
Yeah,
And
exactly.
if you're gonna pay some, what do you gotta think about? I know it's a very specific question that I'm looking for a specific answer for.
Do they have insurance?
But you wanna start lighting somebody up. What do you gotta consider about their overall well-being? Mental status and pain, right? You're literally shocking them 60 to 80 times a minute. So start thinking about pain administration, some anxiolysis as well.
And when you start controlling that, when you start to sedate them or do pain control, now you're taking somebody who's already got their circulation jacked up. Now you're messing with the A and B, right? So just food for thought.
All right, ready break, 5 minutes. We'll come back and talk a little bit about PD.
Hey, everybody online, welcome back. We're going to continue today with Dr. Blake Davidson, PAB. He's going to be talking to us about the pediatric cardiac arrest. So, by the way, if you haven't done so already, please fill out an attendance form. There's a link in the Q&A section over to the right of your screen. You can find it. The password for today's attendance form is hard. Please fill one of those out, even if you don't need the Con-Ed certificate, just so that we can get your feedback and so that we can capture how many people are participating in our program. Thank you. Go ahead, Dr. Davidson.
All right, and those online that can see me, I promise I'm the same person. I just am repping a different team for this lecture. So we'll talk. Did this? We end up getting this working. Nice. Oops. There we go. So pediatric cardiac arrest, pediatric resuscitation. Obviously, it's going to be a little bit more different, or a little bit different. It's going to be a little bit more concerning for most of us. A lot of us are going to be a little bit more on edge whenever we're dealing with a pediatric cardiac arrest. For those who have not run one, I can tell you from my experience, it's something that you'll never want to do again, and is very, very difficult. So we need to be prepared in the best way possible, right? Practice is going to get this into our heads, into a fact where it is just second nature, to where that we're having to think less on the job and just react, right? I don't have any disclosures. So our learning objectives here, we're going to be able to treat neonatal and pediatric cardiac arrest. We're going to be familiar with the dosing of cardiac drugs, right? It's the bane of my existence is pediatric medications, right? It is terrible and miserable. Luckily, we have some cheat codes when it comes to cardiac arrest that help us out quite a bit. And then trying to identify some common causes of pediatric arrest. I want to start out with some neonatal resuscitation. Reason I want to do this is because have any of you guys delivered a baby in a house? Right, so we've got a couple, either in a house, in a road, in the back of a car, whether it be, you guys, we need to know how to deliver one, but then we also need to know how to take care of the baby after the fact too, right? And some of the common causes of neonatal demise and what we need to be prepared for during not only the birth, but after that birth. Nearly 10% of all births will require some sort of resuscitation. That doesn't mean full-blown CPR, doesn't mean intubation, but some sort of stimulation, some sort of positive pressure ventilation, some sort of oxygen blow-by in order to be able to help this child come around. A lot of these complications during pregnancy and during the birth can affect the child's after birth course, right? So if the mom's using drugs, if we didn't get adequate prenatal care, if they're hyperglycemic, they've got diabetes, that can affect a lot of the course afterwards. Taking a complete history is extremely crucial for neonatal resuscitation, right? When it comes down to how far along are we? Did they get any prenatal care? Have they had any complications so far? Do they know their blood type? What's the mother's medical history? What medications do they take? Social history, right? All of this is extremely important when talking about a neonate that needs resuscitation. So when we talk about a physical exam in a newborn, what are we mostly talking about? What are we mostly going off of? If you got a neonate, somebody's going to ask you for pretty specific, right? APGAR, right? We don't know what APGAR is, what it stands for. Yep. I forget that all the time, and I got to look it up. But so, and when do you get it? Right, I have 1 in 5 minutes, right? So right immediately, and then 5 minutes. So appearance, pulse, grimace, activity, and respiration. Okay. And then at the end of this, you can consider blood glucose in neonates of diabetic mothers. So there's our scoring system here. So which is worse, peripheral cyanosis, like if they've got blue extremities, or central cyanosis, right? Central's a bad deal. That is a really bad perfusion. Some of these kids that have peripheral cyanosis, they've got blue hands. Yeah, what's up?
You mentioned consider blood glucose. What would be normal for a newborn?
You want to be above, definitely above 60, but above 80. And then, so this peripheral cyanosis can be a normal finding and can persist up to 2 days. So if you see a kid that has like blue extremities, but they're otherwise well perfused, the central portions are perfused, that's a little bit better of a sign. Pulse rate's important on these kids. It can kind of end up determining whether or not we're going to start CPR or not. All right. So for most children, most neonates, we're going to provide routine care. We're going to provide just stimulation. You'll warm them up, you'll wipe them off, wipe all the grossness off of them, put them on mom. They're going to be all right. Okay. Some of these kids, we do not routinely suction children anymore, right? We do not stick a bulb down their nose and down their throat routinely anymore. The only time that we do that is if there are signs of actual obstruction. Very low birth weight children and children below 29 weeks of gestation should be placed in the polyethylene bags. Do you guys have there are some specific bags that they put children in, like the NICU teams that go pick people up?
Trash bag works for you.
Exactly. If they're small, you put them in a gallon baggie, right? You can put them in just some sort of plastic bag. And why are we doing that? Temperature control. Yeah, absolutely. So yeah, trash bag, whatever kind of a plastic bag, which sounds wild, but yeah, preferably not over their head and nose, and don't zip it up. All right. So resuscitation of the children of the neonate. The scary part of this is you don't do you kind of watch them for a minute, which is terrifying. You got a very newborn child that's not doing too much for the first 30 seconds. You're kind of just messing with them, right? You're rubbing them with the blanket, rubbing them with the towel, getting all that stuff off, trying to stimulate them and dry them off. If they don't really have a response, then you can do a jaw thrust and see if that initiates any respirations and put them in that sniffing position. Then after 30 seconds, if you're not doing anything, if the heart rate is greater than 100, but they're still not breathing, that's when we can start to consider suctioning, right? So it's a little bit further down the road that we're even thinking about suctioning. It's not routine, and it's considered. You don't have to do that. Naloxone is not indicated in neonatal resuscitation, okay? Regardless of exposure of the mother. If the mother, it doesn't matter if the mother has recently done opioids, naloxone is not indicated in the resuscitation of a child. If in that 30 to 60 second range, if their heart rate is less than 100, that's when we're initiating some positive pressure ventilation, okay? When we're going to start to either bag this kid or put on some CPAP if you got it. I know these small children, some sort of positive pressure ventilation. We're going to use room air too. Okay, this is kind of an important and a unique delineation. And neonates, we're not going to use 100% O2. 100% O2 in these children can actually cause some damage, cause some hyperoxic damage, some cellular breakdown, and cause some brain damage. If you need to intubate this child, you can cut the ET tube in half, or down to a shorter period or shorter length, and just move the adapter to be able to help you out, and you're not dealing with a long dangly tube that's going to flop out. So if a newborn remains with a heart rate below 60 beats per minute despite the positive pressure ventilation for 30 seconds. So right, we're not even starting positive pressure ventilation until that 30-second mark. So then you're initiating the positive pressure ventilation for another 30 seconds. So that means about at 1 minute, if their heart rate isn't above 60, despite your interventions, that's when we're going to start chest compressions. Okay. So the ratio for a newborn is 3 compressions to one breath at a rate of 90 to 30 per minute. Okay, so it's pretty quick and it's a pretty difficult thing to be able to actually obtain. But that is the guidelines here. If they're still bradycardic after a minute, then we can start to consider epinephrine. So the other thing about neonatal resuscitation is actually when to not resuscitate a child or not to resuscitate a newborn. You get called out to scene, and a woman has had a child in the middle of a supermarket, and this fetus is less than 22 weeks of gestation, and they weigh less than 400 grams. It is recommended to not resuscitate that child. It is a non-viable fetus, and it is not going to survive almost certainly no matter what you do. Okay. Neonates with no sign of life after 10 minutes, it is reasonable to consider discontinuation at that time as well. Okay. From an outside hospital standpoint, I would be extremely cautious in that. I would not fault at all for bringing that child in and bringing that to the hospital, not only for for you guys, but also for the family's sake, for everybody else that is around that sake, in order to be able to get them in an environment that's a little bit more reasonable than than a supermarket or at their home, and put that decision later on down the road. We talked about peripheral cyanosis. That can be normal. So if a kid comes out blue, but everything else looks okay, then that's all right. Pneumothorax is an uncommon but possible cause of respiratory distress. So it's something that we kind of have to think about. If it was a traumatic delivery, if we had to do a lot of manipulation, if we had to pull the shoulder out there because the shoulder is dystocia, or break a clavicle in order to be able to get the child out, then pneumothoraces can occur. Most of them are small, just need observation, a little bit of oxygen, and they're fine. If they develop tension, then you can use an 18 gauge or a 20 gauge IV catheter, a 1-inch IV catheter. Your landmarks are the same, right? Second intercostal space, a little bit easier to find in a neonate. So hopefully that'll help you out a little bit. Hypoglycemia, we're treating children with neonates with D10, right? D10, and we're going to go 5 milligrams per kilogram. Don't know what gastroschisis or omphalocele is? Right, you got exposed intestines. They're a little different in what exactly they are, but at the end of the day, you got guts that aren't on the inside. Okay, if you guys see that during the middle of after a birth, put something wet over top of it. We put like blue towels, the surgical towels over it. But if you've got some sort of normal saline gauze over top, then just cover it, because they're gonna lose a lot of water volume that way. Yes.
Hey, sorry to interrupt. So, Dr. During actually commented to me that for neonates, hypoglycemia is less than 30. Some people even say 30.
Okay.
So,
okay.
Just that's something that's an important point. I think that's probably why he asked it, because we don't really think about that much unless we're in an academic setting. But
right.
Yeah, it's different for the neonate.
Right. Thank you.
I don't necessarily see a situation where we'll take the sugar on an infant, but I don't see many situations where we're going to be giving sugar. I guess my only question is, because we don't reliably always have D10. Most of the time we keep D50, and then also we're not going to be getting IV access If we have to get it, it's probably gonna be intraosseous, and I don't believe Alabama state protocol allows us to give sugar
Yeah.
intraosseous.
That's not true. You can.
It does?
Yeah,
Okay.
you can give, dextrose containing solutions, IO. They used to do an automatic QA on that because people were abusing that. They were abusing patients by starting an IO on frequent flyer hypoglycemic patients in other parts of the state. That's why that rule is there, but it doesn't mean it doesn't work. There's
Well, that was
nothing.
about to be my question.
If you need to give
Yeah.
any patient, any age, a dextrose containing solution, IO,
Mhm.
then you can do that. But certainly, I would talk to medical direction about that as well. You agree with that, Dr. Davis?
I agree. Yeah, absolutely. And getting an IO and a neonate is probably not going to be successful. Like most of the time, like to be able to get the best access in these kids is going to be through the umbilical vein, right? And so you'll use an umbilical vein catheter in order to be able to get your IV access, which is not something, like you said, that you guys would do in the field. All right. So from an overall standpoint, pediatric resuscitation differs from adults in many different ways. The primary cause in adult cardiac arrest is going to be primary cardiac, right? When we're talking about pediatrics, it's going to be primary respiratory. Survival to discharge is also significantly higher in pediatric cases than it is in adults. Kids are resilient and survive a lot longer and with a lot better neurological outcomes than adults do, even with prolonged downtimes. The dosing of medications is weight-based, right? So that is one thing that we kind of really have to pay attention to and be cognizant of whenever we're addressing these kids. Date range or age ranges, you'll see this commonly whenever you're reading things. It's talking about whether newborns, infants, or children. So newborns are considered any child that is less than 1 month of age. Infant is 1 month to 1 year, and then a child would be any kid 1 year to puberty, right? So around 12 to 13 years old, once they get full adult size, which in some states is 8. But what is this? Prazo tape, right? So this is the lifeline of all pediatric resuscitation, right? This helps take most of our thinking out of the picture, right? You lay this down and you look at where the kid lays on the chart, and all your meds that you're going to need are right there in front of you, and tell you the dosing and kind of where to go. Some of these also have equipment sizes as well. Right, so if you're looking at your Broslow tape and you need to intubate a child and you can't, you're all hectic and you can't really think of the ET tube size, and a lot of them are on there. I don't have any claim in this app. There are tons of different apps out there on the Apple Store, but I use an application called Pedistat, PEDISTAT. It's I think like $4 or $5, and it is a lifesaver. I use that for almost everything. Basically, I open it up, I put in a child's age or weight, and then it pulls up kind of everything you need, whether you want airway information, whether you want all your equipment information, or whether you want antibiotic dosing, and it's going to tell you all the exact doses that you need, all the exact equipment that you need as well. So something to think about if you want to have something of your own. Again, a little bit more in-depth look at the specific cases or the specific details of this Broslow tape, right? So you've got your medications, and then what type of concentration that you're dealing with. So we'll even actually tell you the amount in some cases to actually give. Whether or not you're going to be dealing with D5 versus D10 versus D50 as well. And then down here on the bottom, we're talking about all of our equipment. Okay. You guys using cuff tubes or uncuffed tubes in a small child? Yeah. Some of the stuff will still say cuffed or uncuffed tubes, but you can use a cuff tube in almost any child out there. Pediatric airways are difficult, right? They're difficult in a couple different ways. They're difficult because we don't do them very often, right? There's very few instances in which we're intubating children. In all of residency, I had less than 20 pediatric intubations, right? So in 3 years of working 7-8 shifts a month on the pediatric side of the ED and working in the PICU for a month, I had less than 20 kids that I intubated. So it's something that we're not extremely, we're doing every single day, and their anatomy is a little bit different, right? They ride a little bit higher and a little bit more anterior than our adults do. A Miller blade in children is kind of the stereotypical teaching of being a little bit easier to use in children. If you have that, you can go for that a little bit faster. Their tongues are also in the way. Their tongues are a lot larger compared to size than adults. And then from an anatomy standpoint, the younger children, their heads are a lot larger compared to their body than adults as well. So actual positioning of the child is important. It's hard sometimes not to overextend them because they have no musculature within their neck, right? They can hold their neck up. Infants less than 6 months old are primary nasal breathers. Another thing to keep in mind too. If they've got a bunch of junk in their nose, they can't breathe. They're hypoxic. Try and clear them out that way. And if you're using a bag mask ventilation, that they need some nasal option. So choking in a child, if a child is choking, we're going to use back blows and chest thrusts are recommended. We're not using Heimlich in children less than 1 year of age, right? We're not using the blind finger sweep anymore. That is not recommended. And why is that not recommended? All right, the possibility of pushing that thing directly further into the trachea. Children who are conscious in choking, we should not be doing much to them. You can try and do some back blows, but try and let them clear stuff on their own, okay, rather than further dislodge it down into their system. Try and let them cough it out and expulse it out rather than banging on them and actually pushing it further down. So these are different airways for kids, right? So they do make eye gels that go down to the pediatric side. I've rarely seen the size 1 eye gel, and I think you said y'all don't have that, right? Really any kind of supraglottic device for a small child. You got King Airways. Some patient or agencies will use. You got your ET tube, and then what is that thing down there? A makeshift needle crike. This should never be, a situation that you guys are having to run into, but something that if you can't oxygenate, can't ventilate a child that is less than 8 years of age, and you need to crike them, you cannot do a formal crike. You can do a makeshift needle crike. You grab a 14 gauge catheter. You grab a 3 millimeter syringe. You hook the catheter up to the 3 millimeter syringe. You take the stopper out. You cut and you can either cut an ET tube or an adapter to a size 7.5 ET tube will go on top of the 3 millimeter syringe, and you can hook it up directly to that. So that will only get you oxygenation. It will not ventilate a child. So once you do this, you have about 30 minutes before this child actually needs a definitive airway. That is not considered a definitive airway. If we're bagging a child, obviously their lungs are not as big as adults, right? So we need to be very careful about lower volumes whenever we're squeezing the bag. Same thing I talked about earlier in the adult resuscitation. If we're squeezing it all the way, we've just got a chance of having that barotrauma. So we need to rely heavily on visualization of chest rise to see if we're actually getting ventilation there, okay? So you see chest rise, you're doing the job, you're getting air in the lungs. That's where you need to be, and not over excessive in that. And decrease the oxygen percentage as possible, right? So don't be on 100% FiO2 if the child doesn't need it, right? Okay. From a CPR standpoint, in infants, our pulse checks are going to be at the brachial artery, right? So up in the mid-humerus Okay. In children, we're going to end up using the carotid and femoral like we do in adults, but in infants, we make sure we're using the brachials. The rate of compression is going to be 100 in children. And then the compression to ventilation ratio is different as well. So if we've got a single rescuer, which we should never be in that case, it's 30-2, and in a two-person, it's 15-2. And once we have a definitive airway, do we care about ratios? No, right? We ventilate appropriately at that point. Technique of compressions in infants and these small children, we're going to use the two-thumb technique, right? So you place a child in both hands. You've got the back of your hands on their spine, and you're putting your both of your thumbs kind of at the lower portion of or lower third of the sternum, and compressing that way. If for some reason the child's a little bit bigger, or you don't feel like you're getting adequate compressions, then you can switch to the two-finger technique over top for chest compressions as well. And in infants, we're going at 100 beats per minute. And children, you can use just one hand for chest compressions. Use the heel of your hand at the lower end of the sternum for chest compressions. Okay. Again, in the South, we tend to be a little bit larger. So you got a 6-year-old that's 150 kilo or 150 pounds. One hand might not get the job done. Okay, so use common sense. If it's don't get stuck to all these guidelines, and take care of the patient. And all right, access. Right, obviously everybody prefers IV access if we can get IV access. At the end of the day, I want access. I don't care where it is or how it's obtained. If I've got a really sick kid, I want to be able to give them drugs that they need as I can, right? So try to get IV access. If you can't, within a reasonable time, about 30 seconds to a minute, get IO access. IO access in children is a little bit different than adults. In adults, I'm pretty much going for the anterior tibia every single time. And kids, most of the time, but you can also use some different sites as well, like the distal femur. I take that back. In adults, you can use the proximal humerus as well, which is going to be the fastest and best, but has some issues. But the main thing in children is that you can use the distal femur in a small child. If you don't have access, and for some reason you can't get IO, and you need to give some meds, you can give meds tracheally. You can give them nebulized. You can give lidocaine and epinephrine and atropine, all of this stuff tracheally. For you just have to change the doses. Generally, it's like 2 times the dose in order to be able to give a medication tracheally. For epinephrine, it's 10 times the dose actually. But I don't even know if we would have that access to be able to nebulize any of that stuff out of the hospital.
Yeah, and for ET drugs, so in this region, if you're working with me, drill them, get IO.
Yeah.
We're not doing drugs down the tubes. And we're definitely never doing medications down a blind insertion device, a gel or a team.
Yep.
And I have seen some of that recently. So standard rule, nothing down the tube, get access.
Yep. Yeah. There should be no reason we can't at least get an IO. All right, medications. Dosages. Dosage of epinephrine and a code in a kid. Perfect. Max dose at 1 milligram, right? All these are going to be max doses of what we talked about earlier in the adult cases. Amio. Close, right? 5 milligrams per kilogram over 20. Atropine. 102. Max dose of 0.1 or single dose of 0.1, and then up to 0.5 total. Your glucose, we talked a little bit about earlier. So in a newborn, 5 milliliters per kilogram of D10. Infant, 2 milliliters per kilogram of D25. And a child, 1 per D50. So there's the rule of 50. Have you guys heard of that or know what that is? Kind of what I'm talking about there. So if you're looking at this, it's 5 mils of D10. 5 times 10 is 50. 2 times 25 is 50. 1 times 50 is 50. Right. So if you're trying to figure out where you're going to end up needing to give, as long as it multiplies up to 50, then that's what you're going to get most of the time. The dose of lidocaine in peds. One milligram per kilogram bolus. Adenosine. .1 milligram per kilogram. Your dosages are still going to be the same. You still titrate it up the same way you would in an adult as well. Obviously, you're not going to be given adenosine in a code, but this is something to think about. So the reason why I kind of mentioned earlier about Pedistat and the Broslow tape is because this is all the stuff that you can figure it out on your own if you want to, right? You can figure out what size ET tube to put in a child if you want to, and this is for an uncuffed tube, but you can use the same size. You go down half a size for a cuff tube. But you take the child's age, you divide it by 4, you add 4, and that's your size of the ET tube. Once you have the ET tube size, from an in-hospital standpoint, that's what I'm gonna base that on everything I do. The most important thing is that whatever size your ET tube is, 3 times that size is the depth that you should be at the lips. So if I put in a size 4 ET tube, where should I be at the lips? 12, right? So, you know, if we got video scope, we're visualizing through the cords, and we've got bilateral breath sounds, then, you know, we're visualizing, or we're confirming it that way, but also we're looking at our depth. If we go in and we look that, or, you know, we hear only right-sided breath sounds, and I'll look down and my ET tube is at 15 centimeters in a 4.0 ET tube, then I probably need to drop back a little bit. Okay. But that's just.
That's not true for adults.
No.
That just applies to, yeah.
Yeah, I mean, it does end up working out for adults. Like the majority of the time, we're going to be between like 22 and 24 in a 7.5 ET tube. But this is, you know, usually for pediatric cases.
You can also do it the old-fashioned redneck way.
Before you place the ET tube, put it next to the face and kind of see where it ought to go. Size it up almost like you would an OPA, right? And that gives you kind of an idea where it needs to go.
I was talking to my buddy like 2 nights ago when I was making this lecture, like going back through it, and I've never heard this before. So from talking about a blade size, his little mnemonic or whatever saying is blade size 2 at age 2 and size 3 in grade 3. So when you're trying to figure out what size of laryngoscope to use, I'm gonna go off that little guy. All right, so I got 2 little cases real quick. We got a 6-year-old past medical history of asthma. There's acute onset, work of breathing. Mom's given 4 puffs of albuterol, no improvement. On scene, child now looks like he's not breathing much at all and appears to be altered. What are we gonna do for this kid? Oxygen, right? So we're gonna put some oxygen on him. Any interventions? Want to get him a DuoNeb? Yeah. Try to help him out a little bit. Just give him a DuoNeb, still continue to have poor respiratory effort, become non-responsive, subsequently loses the pulse. Rhythm's normal, sinus rhythm. So we're going to start CPR and intubate this kid. Okay. You have to intubate an asthmatic. We need to be very, very cautious, right? They have it is one of the more dangerous things. This kid's already coded, but it is one of the more kind of unique ventilator it's a challenging ventilator management, ventilating a person with asthma. We want to do, you know, low tidal volumes over a long period of time. You want to make sure that we're allowing this child to exhale and get rid of all that CO2 because they can get that breath stacking phenomenon that we talked about. Okay. 14-year-old child, history of depression, found out by mother, called EMS. Patient, upon arrival, is pulseless, no spontaneous respiration. While you're starting all of your stuff and doing everything appropriately, you're getting a little bit more history from mom. She says that child was a little nauseous, and mom had some Zofran with her that she gave the child. And she had only taken her SSRI earlier today. What are we concerned that this child has? Excuse me.
Or medication, maybe overdose.
Okay. Yep. The overdose. Remember we talked about earlier with the old lady that, what's that?
QT prolongation.
Yep. Which can lead to what?
RLT.
RNT, and then what rhythm? Yep. Yeah, the squiggly one, the one that looks all jacked up. Yeah, so this here is a different route in order to be able to get to the same situation, right? So there's a bunch of different things that can cause QT prolongation, so medication history is important there. That's when we can start thinking about giving some of our other drugs like MAC a little bit earlier within resuscitation, okay? So there we go. There's the squiggly lines. All right. And then MAG in children is 50 milligrams per kilogram with a max dose of 2 grams. And then so defibrillation in children is a little bit different as opposed to adults, right? We're going to give 0.5 joules per kilogram first, followed by 1 joule per kilogram. I don't know how Dr. Ferguson feels, but I line them up with 1 joule per kilogram on the front end. I am on the higher end of all this stuff. You're not going to hurt the child. It is extremely safe in order to be able to give them more joules up front than later on. I don't like messing around when it comes to that. You have any opinions?
Hey, I'm very likely I'm outdated here, but I thought it was 2 joules per kilogram on the first and 4 joules per kilogram on the second.
Yeah. So the apple has 2 and 4.
Yes.
Yeah, that's the sink dose.
Mm-hmm. Yeah. You're right.
Yeah.
Right.
Yeah, but I agree that the more electricity, the better. So, old school for adults was, 50 for atrial, 100 for ventricular, and then moving your way up. In reality, give the biggest dose you can first of that, and it just saves you time. So same thing with kids. So 4 joules per kilo is
I need to
fine.
change that. Sweet.
But Chief, you are outdated, by the way.
Thank you. Yes, I agree.
That's part of your dose. Yeah, that's part of your dose.
25 to 1.
Questions, comments, concerns?
Good stuff.
Adult or peds?
Yeah, so we had a lot of interaction today, both on text and through the Teams meetings. Dr. Durning was listening in and had a lot of positive reinforcement there. The only correction that he texted me was the glucose level that neonates are typically hypoglycemic.
Yeah.
And that's it. For the questions from EMS personnel were mostly centered around how long we stay on the scene. And, there's a push now to try something different with peds because we really haven't improved pediatric cardiac arrest over several decades. Success has remained stagnant. Whereas with adults, we have made improvement, although we all know we would like to do much better than we're currently doing.
Yeah.
And so there's a push to stay on the scene with medical cardiac arrest peds. I don't know if that's the right thing or the wrong thing to do. I've done it a couple times. It seems very unnatural. But I don't know if that's just an issue of familiarity.
Yeah.
Because it seemed pretty unnatural when we started doing it with adults as well. So I don't know. I think that's just food for thought for everyone. I think the data is really important because we can't make good decisions without accurate data. And again, I'd encourage everybody who's at a transport agency to make sure that you're just taking care of the data's good. Dr. Ferguson, you got anything to add to that?
Yeah, so again, medical emergencies, you should work them where you find them. CPR in the back, or chest compressions in the back of a rescue or ambulance, whatever you want to call it, are not super effective, even on kids, my opinion. Remember, kids have a lot of these are respiratory problems, so manage that airway on the scene. Passive O2, good BVM use a BIAD, okay? Our early first dose epi, make sure you're doing that correctly. All right. I know I've heard Dr. During say that he wants these guys to work in the field as well, but I won't speak for him. But my thought is If it's something you can manage, manage it, right? If it's a trauma, you can't do that. If you can't manage the airway, then you gotta do something passive O2 and move toward the hospital. But we are the lifeline for these people, right? And if we can't do good quality care, if we're moving down the road, we do it where we find them, all right? So other things, Lapedes, think about, they're really switching, we're switching to the using cuff tubes. If you have to intubate a kid, you probably want a cuff because when they put them on the ventilator, it helps with the management of that. Remember that kids, intubating children less than 3 is category B. That doesn't mean you can't do it, but that means usually if you do passive O2, good airway management, BLS skills, ambu bag, IGL, OPA, you can do pretty good work with that. One of the cases that he was talking about, that asthmatic that goes into cardiac arrest, what is the first drug you want to give them that helps both epi? So epi's great for asthma, great for cardiac arrest. I would push that for you pediatric drugs. Even for me, I got to step back and look some of the things up. There's a couple of drugs you got to know cold. You got to know the epi dose for anaphylaxis, for cardiac arrest. You got to know it cold. You don't have time to pull out your cheat sheet, figure things out. Those you got to memorize, right? The glucose, you got to know cold. You got to memorize it. Everything else, you got time to step back. You're doing your ABCs, you're giving your first dose of epi. Now, holy crap, they're in VTAC. Why is a kid in VTAC? Okay, what's the dose of amio? Somebody's looking that up as you're doing everything else. Epi and glucose, you got to know cold. And I would say, unfortunately, in the world we live in, you probably need to know Narcan as well, right? Cool.
We talked about this yesterday. I don't want to bring it up, but in the case of a patient in severe asthmatic arrest or severely asthmatic to the point where you've had to place a definitive airway and they become peri-arrest or do arrest, look for tension. They can pop their lung and they can put a lot of pressure in their chest.
Yes, think about that. And even if it's a asthmatic that's making you uncomfortable, they look sick. And I define sick as somebody that I'm looking at and I'm using profanity thinking, holy crap, they're fixing to die, right? And asthmatic, IM epi is a great drug. You can't get IV access, you give it nebs. IM epi till you get your access and do other things.
Yeah.
Okay.
I think to that point, if you've intubated an asthmatic person and they get better and all of a sudden they start to decompensate, what's the first thing that you should do?
Check the tube.
Check the tube, but also what?
Tension, check that.
So-
Breath sounds.
Tension. Before that, you can unhook the bag, push on the chest, and they can breath stack, right? So they're not able to get all the oxygen out. If we're hyperventilating them, we're filling the lungs up with air and not allowing that air out of the chest. And so you take the bag off, push down on the chest and try and see if you can get some exhale. And sometimes that'll fix the problem.
Yeah,
If that-
ventilator management, airway management on an asthmatic, this tube is complicated.
Mhm.
It's kind of counterintuitive.
Yeah.
Those are sick people.
Yeah.
So that's the exception. I would say you're doing your primary ABCs, doing your airway management, your IM epi, you're working with them. But in the back of your mind, you're thinking, these guys are sick as dirt. I need better drugs and therapies that the hospital has.
Yeah.
So they're moving to the hospital pretty quickly. Remember, great talk, sir. Thank you so much for doing this. Always good input to have the docs kind of talk about how they manage these things. Remember that even though in the past, a lot of people have pushed away from aggressive airway management for outside of the hospital. My thoughts on that is that we should be the airway gurus. We should be managing these airways. That doesn't mean we don't do chest compressions early. That doesn't mean we don't do adequate IV therapy, but that means we do passive O2, bag valve mask. If we go to an IGL, then we eventually come back around. If you got a video scope, you intubate. Okay. We just got to be the airway gurus. All right. The other thing to think about is that as EMS providers, when you're asked by citizens to teach CPR classes, first aid classes, don't roll your eyes and think it's a bad thing. It's a good thing. They're asking for help. They're your first responders, right? So teach them hands-only CPR, chest compressions, and that will give us a better chance to resuscitate some of these people. Okay.
Remember that odds ratio that we looked at of bystander CPR, 3.7.
Yes.
Yeah,
Makes a big difference.
pretty low. And it's pretty regionalized too. So that's one of the factors I think that you mentioned, but really your outcome from out of hospital cardiac arrest, the most important factor that I've seen in the data is where you were when you had, which jurisdiction you were in.
Yep.
And so that should all make us feel bad if we're not the number one jurisdiction.
Yeah.
Because it means it's possible to do better.
Right.
So, Dr. During did, talk a little bit about incidents of pediatric out of hospital cardiac arrest. So the numbers are a little mixed. Pediatrics overall do have a better outcome, but you really have to break it down by age. Kids under 1 are 6% or less, which is lower than adults. So, and there's a big gap between pre-2015 and post-2015. And there's been pushes of apparently in several areas of the United States to stay on the scene and work pediatric cardiac arrest, and that seems to be showing some improvement.
Yeah.
So I think that's something we got to consider. We can't get bogged down in the way we've always done things. We have to really think about things and study things, use the data to make good decisions to always improve. And if we're continuously improving, I think that we're doing our job.
CARES data, put good data in, get good data out. And the last thing I'll say on the kids is, as far as managing on the scene, when that mom or dad brings that kid out to you that's blue and screaming, throws them to you, and you take them and you run to the back of the ambulance, then y'all drive fast and you start doing things en route, you have delayed airway management for minutes. So manage the ABCs, the things that you should be able to do immediately, and then think about your transport decision. All right, we're at Mountain Brook in 2 weeks. We'll do skill labs there. We're here at Trustful Fire and Rescue. Thanks again, Chief, for having us out here. We're gonna do airway management. We're gonna do some ultrasound training. I got a few pig trachs. Survival Flight 16 just landed, so we can do some airway skills with them as well, and we'll do some mega codes. So if you're in the area, come out.
Yeah, great turnout here with Trustful Fire. Thanks, Chief Schatz and Chief McLaughlin for letting us be here today. Really good turnout. If you're in the area, you can still come by, grab some lunch, and do skills with Doc and the crew from the helicopter and all those team members here. And otherwise, we'll see you next time. Everybody have a great day.